Good evening, and thank you for joining us tonight for Pain Management and MS. My name is Laura Allen. I am a Programs Manager at Can Do Multiple Sclerosis, and I will be your moderator this evening. Can Do MS delivers health and wellness education programs to help families with MS thrive. Please visit our website, cando-ms.org, to learn more about Can Do MS's nationwide programs. This year, we're offering our programs online in lieu of in-person programs, and so do visit our website for some new offerings that we have, as well as our virtual Jumpstart programs. And we do have a new set of programs coming up called Coaching, Connections, and Coffee. So take a look on our website for that. The mission of the National MS Society is to help people affected with MS live their best lives as they stop MS in its tracks, restore what has been lost, and end MS forever. You can explore other societies' programs, services, resources, and connection opportunities at nationalmssociety.org. We will save about 20 minutes at the end of this webinar for questions and answers. So if you have a question during the presentation, you can type it in using the questions chat box found in your control panel. The presentation is being recorded and will be archived on the Can Do MS website. You can download a copy of tonight's presentation and additional resources from your control panel. You will also be able to access these resources in the follow-up email. Our speakers this evening are Abby Hughes and Eliza Ben-Zachariah. Abby Hughes is a clinical psychologist and an assistant professor of physical medicine and rehabilitation at Johns Hopkins. She specializes in rehabilitation psychology and MS rehabilitation. Thank you for being here, Abby. Welcome. Eliza Ben-Zachariah is a dual board certified acute care nurse practitioner and an adult nurse practitioner. She is a certified MS nurse with experience in acute care, neurology, and rehabilitation. She is a full-time faculty and assistant professor at Hunter College Bellevue School of Nursing. Good evening, Eliza. Thank you for joining us.
Thank you.
And with that, I'm going to turn the meeting over to Eliza.
Thank you, Laura. So the objectives for this for tonight's talk are a few. First, to understand the types of MS, of pain that can occur in MS, understand the impact of pain on your quality of life and daily functioning, including relationship, and explore a few strategies to manage your pain.
So sometimes it's helpful to begin these presentations with a discussion on the definition of pain. People experience pain in a wide variety of ways, and we'll be talking about some of those experiences tonight. But the basic definition of pain is an unpleasant sensory and emotional experience. And we highlight the fact that this is both sensory and emotional because sometimes people experience it more sensory, and sometimes people experience it more from an emotional standpoint. It's actually associated with either actual or perceived tissue damage. So although you might not be able to see the damage, or even it may not even appear on an MRI scan, there could still be the perception that damage is occurring to the body, and that creates a sensation or an experience of pain. Another definition, which I really like, is it's whatever the experiencing person says it is, existing whenever and wherever the person says it does. This really puts the control back in the person who's experiencing the pain to describe it, to communicate what that experience is like to their family members and providers. And it gets at this idea with an MS that pain is often an invisible symptom. Just because it's invisible does not make it any less real or valid. And importantly, which we'll be discussing tonight, it can be treated.
So what are really the characteristics of pain? And I'm sure many of you experienced at some point at your life pain. And it can be multifactorial, many potential causes for MS pain. It can be related to your disease, can be unrelated to your disease. It can be variables. Very often, it can change over the duration of a day. It can change over a few months. It's almost never the same pain. It can be unpredictable, not the same pattern, and it can have a sudden onset. It can be acute, that just happened for a few days, and you feel the intensity of the pain, or either it can become chronic pain, which usually tends to be approximately 6 months or longer for chronic pain.
So why don't we start this evening with a polling question. What are some of the ways that you describe your pain? And you can select one of the following. Does your pain come from multiple causes? Does it change often? Do you find that it's unpredictable? Do you find that it's in different locations? Or do you experience it as different sensations? Go ahead and select one, or if you have the option to select multiple, you might be able to do that. And we'll go over the results together in just a moment. Okay, so about a third of you said that your pain is unpredictable, and that was the most common response. The next most common response was that there are multiple causes of your pain. So that's very common among individuals with MS, that the most distressing aspect of pain can be that it is unpredictable. So it may come on suddenly, it may come on without warning, it may wax and wane at unpredictable variations, and that there may be multiple causes, right? So you can try to chase the causes and try to address the pain, but it may be coming at you from multiple perspectives. And then several of you also said different locations and different sensations.
There is no questions that you feel different sensation. I recall many of my patients describe the pain as tingling pain, as an itch, as a pressure-like pain, as something crawling on your skin, as mild, as intense pain, as pressure. And you can see that the list go on and on. I think was mentioned earlier, whatever way you describe it, it's a valid pain. And often I tell patients that the nervous system can be weird, and that's why we feel all these unbelievable sensations.
So let's go through another question for the group. How often do you experience pain? Go ahead and select the option that best describes your experience. Okay, so almost half of you described experiencing pain very often, meaning nearly every day. Another 42% of you said that it happens sometimes too often. This is very common with what we know from the literature and from clinical experience of folks that we worked with who come in, that pain is one of the most common symptoms associated with MS. And as we said before, because it's so variable, people experience it in different ways. So thank you for completing the questionnaires.
So as you mentioned, many of you experience pain very often. So you can see what is the prevalence of pain in patients with MS. Approximately 50% of patients with MS are affected with pain at some point of their journey with the disease. 20% of them mentioned that it's at the disease onset, so early after the diagnosis. And 25% reported experiencing very severe pain that affected probably their quality of life and their level of functioning. And more than 50% of people with MS have pain more than one place. And you have mentioned that you have experienced pains in different places with the unpredictability of pain sensation.
So we talked about how pain can come from different sources, and you all responded similarly to that in the poll. We know that pain can be directly related to MS, and this is not something that's always talked about at, for example, an initial diagnosis appointment. There's so much to get through that sometimes the providers doesn't always have a chance to go through the whole checklist of potential experiences. But pain is certainly one of them, and it's an important one. When you have a new lesion, for example, it can cause direct neurologic sensations, and optic neuritis is a good example of this, where sometimes people experience the severe eye pain as their first sign of MS. There can also be demyelination or lesions in the spinal cord, and that can lead to what's called neuropathic pain, which Aliza will describe in a little bit. But we also can have pain that's indirectly related to MS. So, for example, if your gait and posture changes over time, that can lead to some joint pain. And so some chronic pain issues can develop because of how you've been coping or how you've been trying to accommodate or adjust to your gait changes. Then we also know that MS can cause depression, which increases pain. It increases the experience of pain. So it can increase the pain intensity or pain sensitivity. And this is well documented in the literature that there's a high overlap between the experience of depression and chronic pain. So much so, which we'll talk about later, that some of the treatments are similar. And then pain can also be completely unrelated to MS, but still affect how you manage MS. And a great example of this would be if you have a condition that causes pain, like arthritis, you might have to take a new medication for that, and that medication might interact with your MS medications. So it becomes a complicated management puzzle to put together with your healthcare team in order to best manage your pain while also addressing your other health conditions.
One of the highly common pain sensations in patients with MS is neuropathic pain. So what is really neuropathic pain? This is a pain that is often caused by damage to the nerves, so directly related to your disease. And it often feels like pins needle sensation, burning sensation, vibrating electrical shock you can feel, itching sensation. Very often as clinician, we call it paresthesia, so dysesthesia. And it's all being some kind of a sensory effect, like mostly burning sensation and pins and needle. Another type of pain is musculoskeletal pain. So this pain, it's mostly either indirectly related to MS or either unrelated completely to MS. So it's mostly associated with injury to the muscle or bone, for example, a sprained ankle or knee problems. And often caused by changes of strength. Often patients with MS, their posture changes, or they have weakness or spasticity, stiff tone and rigidity that can lead to pain and often affect your daily function. For example, very often patients with MS will have a one-sided weakness and developing a foot drop in your foot. So there will be change in your walking, change in your posture. You put more effort on the more stronger leg, and sometimes it can cause some arthritic changes, which will cause hip or knee pain or back pain. That the management will be definitely different to neuropathic pain or musculoskeletal pain.
So in this poll, could you tell us a little bit about what kind of pain you experience? So based on Aliza's description, do you experience neuropathic pain, musculoskeletal pain, both, or neither? And by far, 68% of you said that you experienced both, and that's very common, and that's why we want to address both kinds of pain this evening. And also, if you are watching this with a partner, support partner, friend, family member, hopefully that this is an educational opportunity to talk about why you might be experiencing pain in different ways, and how your pain might be different from day to day depending on which kind of pain is more predominant.
definitely a very high number of you, almost 70% really experienced either neuropathic pain or both neuropathic and musculoskeletal. So how does pain really affect you? Definitely affect your performance throughout the day, with your daily activity, with social activities, social outing, relationships with the family members, at work. It affects every minute of your day, also including views about yourself, about your self-esteem, about your self-worth because of the pain that limits your activity. And in general, overall, it affects absolutely your quality of life.
And again, the impact of pain can span multiple dimensions. So we've talked about the cognitive effects, the physical effects, the emotional effects, and the social effects. To Eliza's point as well, depending on how long you've been living with the pain or how you cope with the pain, that can also affect your experience of the pain, how intense the pain is, and your ability to function in daily life. So as we transition to talking about not just facts about pain or the prevalence or the impact, we will start to shift more to thinking about what are some strategies that may be helpful. And the benefit is, if you know that pain can overlap with these various areas, when we focus on these areas for treatment, it can also help improve pain. So it goes both ways. So that's one positive take home from tonight, is that while pain is complex and it affects many parts of life, you can use those many parts of life to help manage your pain as well.
As Abby just mentioned, it's a complex problem, but it is manageable. The overall management of pain is probably trifold or bifold. I think the most important information related to management, to make sure that it's individualized to your need, that there is an assessment. The most important information is to identify the trigger to the pain and what are the causes for the pain and what type of pain. Because once you identify the source and the type of pain you have, we can manage this better. And that requires partnership and discussions about your pain almost every visit. And it includes pharmacological strategies. We'll talk in a few minutes about medication. However, the important approach is to always start with non-pharmacological approach. What I mean by that, of course, non-medications. And other approaches would be rehabilitations, physical therapy, occupational therapy, using, for example, tense units and yoga exercise, and other complementary and integrative medicine approaches. The most important also piece of information that it has to be a team approach. And I mentioned the partnership has to have a lot of discussion between you and the MS team, and including your HCP, the healthcare provider, the primary care provider.
Absolutely. So I'm curious, of the folks on the call or the video tonight, how often does your MS provider ask about pain? And maybe you have multiple MS providers, so it may differ, but maybe if your most recent visit for that provider, how often do they ask you about pain? Is it every visit, most visits, some visits, or only if you bring it up? So almost half of you said it's only if you bring it up. So I'm really glad that you've answered this, because it tells us a lot about what community providers are doing and how they're prioritizing asking about pain as a symptom in MS. And it can also help, again, us as providers be better advocates for what we want to focus on and how to provide more education to other providers throughout the country on this.
So let's talk a little bit about pharmacological management, and then I'll gear towards the non-pharmacological, although, as I mentioned, it's always important to treat first with non-pharmacological pharmacological strategies, and then try medication if it was not helpful. A few principles about pharmacological pain management. As I mentioned, important to identify the type of pain. Is it neuropathic? Is it musculoskeletal? Is it something else completely unrelated to MS? Important to really identify the type. Always important to think about your other diseases. We call it comorbidities, but other chronic illnesses, or not necessarily chronic, but always you need to know what other disease, because we want to manage not only your pain in MS, but also making sure that we don't have contraindication to other medication you're on, or either interactions with other medication, or it caused some double side effect due to your medication for others. So always important to be honest and discuss your other diseases and any medications that you take, either complementary medications, herbal medications, or anything you take. It's really important for the decision making related to pain. Other principle that are really important is to always start with the lower dose. As a prescriber, as a nurse practitioner, I always started with the lower dose and titrate up. Always use one medication at a time. It's not healthy to try one medication and take over-the-counter other medication to treat the same. You have to really do it over time and have realistic expectations. Sometimes it takes some time to really control the pain sensation that you have, especially if you have pain that's multivariables and have multiple sources and triggers. It's important to really minimize too many medication. That's what polypharmacy means, and really go very slowly up, and sometimes even try to treat two conditions with one medication. We do it very often when people have depression and pain. You can prescribe one medication that can address those two phenomena. So it's really important to try to minimize polypharmacy.
So curious, how do you usually manage your pain? Knowing that there are many different choices and approaches, most of which we'll be covering at least to some degree this evening. We have medications, rehabilitation strategies like physical therapy or occupational therapy, or rehabilitation psychology services, complementary methods, or a combination of modalities. So most of you are saying that you have a combination of modalities. 55% of you said that. And that's pretty much what we see as well, is that with a complex symptom like pain, it takes a complex approach, and often a lot of guessing and titrating and working with your healthcare team in that process. One thing that Eliza mentioned that can be really difficult is to advocate for yourself as the patient in that environment, right? If you're not trained as a physician and you haven't heard of a medication before, it can feel like you're challenging a doctor, challenging an expert, when it's perfectly acceptable to ask questions and saying, what does this mean for me? Here are my concerns. Here are the other medications I'm taking. What can I maybe expect about side effects? And when should we reevaluate if this is working for me?
I think very often combination of modalities are very effective for patients with MS. But as I mentioned earlier, try always. It doesn't matter if it's a complementary or medication that was approved by the FDA. Always do it as a step-by-step and not introduce too many new things at the same time. And I'm sure that you have done that. So talking about classes of pain, and I will just talk in general about the family and how we treat pain, and what is our prescribing patterns for patients with MS. So I can tell you that for definitely the gold standard for neuropathic pain is anticonvulsive medication or anti-epileptic. And what that means is medications that are treating seizures or convulsion, and they were found coincidentally to really manage pain and minimize pain sensation, especially nerve pain, that is, pains that caused by damage to the nerves and highly common in patients with MS. As you recall, we talked about it earlier. And the medications are variables. Either you probably heard some of the name, gabapentin, which is Neurontin, or Lyrica, or GABA, or Tegretol, which is carbamazepine. There are a few under this family. Another family that we often treat pain in MS, either neuropathic or other sources of pain, is antidepressant. There is one family in particular, it's called the tricyclic antidepressant, but medication that we can treat pain. Both the anti-epileptic and antidepressant you have to take every day as a routine. It's not when the pain appears and you take a pain pill. It's something that has to be embedded into your routine, and you take it either on a nightly basis. Very often we tell this the antidepressant family to take at night because it's also minimize waking up at midnight or in the middle of the night to go to the bathroom, because it does have an effect on the bladder, which sometimes, as I mentioned, it's good to treat two symptoms with one medication. So it's very effective that way. Other medications that can be taken for pain, although for temporary relief and for a short period of time, it's the family that's called NSAID. It's an anti-inflammatory medication, non-steroidal, so it's not steroids like when you get it for your relapse. It's non-steroidal, but they have a robust anti-inflammatory systemic effect. I'm sure you're familiar with Aleve, with Advil, ibuprofen. It's all under the same family, but each one of these medications have a side effect. So it's important, as Abby mentioned earlier, to work with your team. Always have an exchange and always inform us about all the medication that you're on. It's very critical. Narcotics, I'm sure you're aware of the narcotics crisis in this country and many other places in the world. Important to treat certain type of pain if it wasn't relieved by other. Usually important to treat for shorter period of time of narcotics, because sometimes you can build tolerance and you need higher dosage as time goes by. And it has some side effects on your bowel and bladder issue, but bowel especially issue, cognitive functions. So important to think about that. Again, if you have pain, you want to treat it, but you want to do it in the least intrusive way. Another new thing on the block, it's medical marijuana, of course, and there is many products on the market, a combination of CBD and THC. Hopefully there is one product that hopefully will be approved this year or by next year, by the first quarters, that will be controlled by the FDA, hopefully. But there is very minimal research studies preaching for the use of medical marijuana in MS. There is some data about spasticity. We definitely need more research about the effect of marijuana on cognitive function of patients with MS. So definitely there is a need of more research. But work with your team. That's what's so critical. Lastly, we talked a bit earlier about rehabilitation and complementary and integrative medicine. This is what KIM is. There are different modalities by rehabilitation specialists. I work very closely with our PT, physical therapist, and occupational therapist. I use very often acupuncture for trigeminal neuralgia. Trigeminal neuralgia, it's pain in one side of your face. Can affect your swallowing, eating, speaking. Can be very severe pain for a longer period of time. Acupuncture seems to help. Always be open to try different safe modalities when discussing them with your team. Always consult with your team and be open to try non-pharmacological first, then try pharmacological if it wasn't effective. Very often, yoga and different exercise can stretch your muscle, can reduce and minimize pain sensation. Important to think what's really working for you. There are some people that yoga, stretching exercise would not work for you, but important to try to combine mind and body. It's usually work together. So I would like to do a probably 1 minute cat-cow exercise, stretch in the chair, and then Abby will do a mindfulness session after that, a short session. So if you can just, then you can do the cat-cow in a chair or either on your knees and hands. But for us, I think for many patients with MS, chair yoga, it's something that's so effective in stretching your muscle. And sometimes you can do a very quick movements that can really lead to very good outcome and relaxations and hopefully reduction of your pain sensation. So if you can sit on your chair and put your 2 feet on the floor, the feet needs to be on the floor, and you're really working on your breath as well. And now once you relax, your hands are on your thigh, and try to inhale as you arch your back. That would be the cow motion position. I'm sure that many of you, so you try to inhale and arch your back. And you can close your eyes if you want, and then exhale and go into the Kate motion all the way, exhale. And then one more time, you inhale and arch your back. You don't need to flex your head too much, just look a little forward, and then you exhale. The recommendation to do it about 5 times. You can do it daily, you can do twice a day, whatever is comfortable for you. And you work on your breath. So you inhale again as you go up, and you exhale as you go down. Usually a very relaxing motion that allow you to stretch, and very often patients feel less pains when they are able to relax. The chair shavasana I won't go on because Abby is doing the mindfulness, but it's something that you can experience if you're a yoga enthusiast. You can do the chair shavasana just to relax and put one hand on the top of the other, close your eyes, and try to just focus on your breath. But I will transfer to Abby. I hope you enjoy this very short exercise.
Okay, so I realize that for some of you on the East Coast, it's 8:30, and we're going to be doing a brief 1-minute body scan activity. You may find yourself getting a little bit sleepy with that, and that's perfectly fine. The purpose of a breathing exercise is, there's multiple reasons, but one can be to help focus our attention, on the moment, on our sensations, on our thoughts, and try to only focus on one thing at a time. So for the purpose of this exercise, we'll be focusing on our body and doing a body scan. And this can be done regardless of whether you have sensation in all parts of your body or just some parts of your body. It can be done whether you're sitting or standing, if you're in a chair or a power chair or wheelchair, using a walker mobility device. At any point during the day, you can take a pause in your day to do a 1-minute body scan. So I would encourage you to take a moment to take some deep breaths in for about a count of 5 and out for a count of 6. And I'll go ahead and count with you. Let's inhale 1, 2, 3, 4, 5, and out 2, 3, 4, 5, 6. In and out. And in and out. Setting the tone for our breath is a really important piece of pain management. Part of that being when we feel pain, our first reaction is to take a deep breath in and go. And in doing that, we become less effective in the use of our oxygen. It can actually exacerbate our pain more. So while I don't promote that breathing and taking deep breaths completely eliminates your pain, or doing yoga eliminates your pain, it's another strategy that you can use. So as you continue to start feeling a little bit more relaxed, start to notice a part of your body. You can start at your head, you can start at your toes, or you can start in your gut. Where you start doesn't really matter, but focus on that part of your body. Close your eyes if it's helpful for you, and continue to breathe in and out. Focus just on that part of your body and notice if you're feeling anything different. If you're feeling an intensity, if you're feeling pain perhaps, if you're feeling relaxed. And then begin to shift your attention to a part of your body slightly next to that. So maybe if you were concentrating on your head, move down to your ears and down to your chin and your neck. If you were starting at your feet, you can start to move up your legs and into your knees. Take a moment just to feel that wave come over your body as you start to pay attention to different parts, slowly, one at a time, noticing that as soon as you start paying attention to your body, it's going to start feeling differently, because this is the power of our brain. When we pay attention to something, it automatically changes our experience. It changes our relationship with that part of our body. And we can use that to our advantage when we're feeling pain or feeling discomfort. Notice if you're starting to feel tense, if you're sitting and starting to feel uncomfortable. You're about 36 minutes into this presentation, and maybe for you that's a longer time to sit than you're comfortable usually. Take a deep breath in and out. In and out. We could go on with this for quite a bit more time, and you can imagine doing a whole hour or 2-hour session of mindful breathing and body scanning. But the point of today is to give you some skills to center yourself, to take that moment to breathe, and to start to pay attention to your body in a different way, rather than focusing just on the pain or just on an unpleasant sensation, but all the sensations and cues that your body sends back to your brain when we're not always paying attention. We're constantly getting cues, and our brain is responding automatically. By slowing down and taking these moments, we can be more mindful of our surroundings, more present in the moment. And research has shown that this also helps with cognition in MS. It helps improve in attention and memory. And so it's not just doing brain games or working on a cognitive rehabilitation program. Doing these kinds of mindful exercises can also be beneficial for not just pain management, but other symptom management aspects of MS. So thank you for doing that exercise with me. We'll segue then into talking about some of the other psychological approaches that we use for pain management. And the two that I will cover this evening, one is called cognitive behavioral therapy for pain, and another is called acceptance and commitment therapy. They're both common psychological interventions that many therapists, psychologists, and other mental health professionals are familiar with. But they're really developed initially for treatment of depression. And over time, when individuals were starting to present to studies or to their providers with other physical ailments or chronic health conditions, we started to wonder whether similar approaches would be effective for managing what we thought were mostly physical symptoms. And if you think back to our first slide when we talked about the definition of pain, pain can also be a very emotional experience. So cognitive behavioral therapy works to understand what those reactions and thought processes are like for you as an individual. You might notice that if you feel a sharp pain, or let's say you have chronic pain and you wake up and it's a bad pain day. Notice that, that's a thought right there. It's a bad pain day. You might start to think about what emotions then come as a result of having those thoughts, right? So thoughts come into our mind all the time. They can be automatic. They can be things that just kind of pop in and we don't know where they came from, but we react to them. We have emotional reactions to these thoughts. And how we respond to those emotions can then modulate or can affect how intense we experience pain, or how intense we experience whatever the emotion is. So, for example, if you have a sharp pain and your thought is, oh, not this again, I'm having a bad pain day, that can lead to feelings of frustration, feeling overwhelmed, maybe feeling a little bit of helplessness, like nothing is going to fix this. And it might lead you to engage in behaviors then that either exacerbate your pain or maybe don't help, like staying in bed for prolonged periods of time, maybe feeling more irritable around family members, and they may notice some behavioral changes. Again, if you have a support partner watching with you tonight, they might notice some behavioral changes when you're in pain that you might not be communicating with words, but you're communicating in a lot of nonverbal ways. But the thing is, thoughts can really work both directions. If we have negative thoughts about pain, that can exacerbate our pain. We can also use our brain to modulate how we experience pain. So you could maybe think of a time when you were injured and you experienced pain that was very intense or disruptive. Maybe cutting your finger while cooking. Now, you might think of a different time when you were injured, but you experienced the pain to a lesser degree. A common example for this is maybe athletes or former athletes in the group. If you were injured in a game and it was a championship game, you might have just kept running and scored the goal or did whatever you needed to do to get to the success of the game. And then it really wasn't until you were on the sidelines that you actually felt the pain. So maybe not everyone can relate to that particular experience, but the idea being that sometimes we are so distracted by the goal at hand that we don't process the pain until later. And that shows us that there's something called gate theory or gate control theory of pain, where when the gate is open, the pain signals all rush in and we experience pain. When the gate is closed, we don't experience pain, or we don't experience it to the same degree. And cognitive behavioral therapy allows us to try to modulate that gate, maybe close the gate a little bit more so we're not feeling everything so intensely. There's some common beliefs about pain, and this gets to the part of the thoughts about pain that can make pain worse. So examples of my pain will never get better, my pain is unbearable, if my pain goes away, I won't be able to cope. These are common, understandable reactions to pain, especially if you've been suffering and living with pain for a long time. But that doesn't mean that we can't start to chip away at some of those persistent negative thoughts and start to challenge them in small, meaningful ways through cognitive behavioral therapy. So CBT, as I said before, works to reshape or reframe some of those unhelpful thoughts. It won't get rid of your pain completely, and it's important to set expectations up at the front that if your pain is a 9 out of 10 every day, a successful treatment might be getting it to a point of where it's a 6 out of 10. It might not be a 0. But if a 6 means that you can do more activities in your life, you can be more present with your family or friends, you can accomplish more in the day that you want to accomplish, then that's really the goal of the therapy. It's less to eliminate the pain and more to have you be more active and participating in your life so that the pain doesn't take that part of your life away. The other type of therapy I mentioned before is called acceptance and commitment therapy. And this works to increase our flexibility and to adapt and work with what is and not what could be or should be. I don't know about you, but I can fall into these mental traps of saying, oh, I could have done this or I should have done that. And that type of thinking can often make pain experiences worse, right? Oh, I shouldn't have sat on the couch all day yesterday and now I have back pain. Or, I should have been more active when I was younger and maybe I wouldn't have put on so much weight now. These are some really judgmental thoughts that I've heard patients express in sessions, and how that guilt or that criticism of oneself can definitely exacerbate the pain. So the point of acceptance and commitment therapy is not to give up or be helpless. It's to become an active participant in focusing on what you can change or what you can control, and not trying to fight so much against the pain, but work with the pain. So kind of like one of those finger trap toys where the harder you pull or the harder you struggle, the tighter it gets or the more painful it gets. Acceptance and commitment therapy works to work with your pain instead of trying to fight against it. ACT, or acceptance commitment therapy, also works to identify situations in your life where pain contributes to suffering. So we often use those terms synonymously, but the beauty of psychology is language, and how we use language is really important, and it changes our experience of the world. So pain, or the experience of pain, does not necessarily have to contribute to suffering. And through this therapy is a way of breaking down those connections so that you can manage your pain more effectively. It focuses on important values in your life. So what are some important things from a work perspective if you work, from a family perspective, from a leisure perspective, what's important for you for engaging in daily activities or hobbies. So instead of avoiding physical activity because it's painful, it's about finding new ways of engaging in physical activity that may be less painful, or ways that give you benefits that make the pain manageable. So with that in mind, just as a summary, we have the CBT part of pain as one treatment approach, and we have ACT. There are a number of other types of psychotherapies, so this is not a exhaustive list, and there's ongoing research funded by folks like the National MS Society and other organizations to figure out what interventions are most effective. But these were two that I just wanted to introduce to you tonight, so that if you do have access to a mental health professional, and there are, the National MS Society has a directory for finding a mental health professional who has experience in working with individuals with MS, or Can Do also has resources to help get people connected. You can explore these kinds of therapies, and you can ask a therapist, do you have experience in CBT with people with chronic pain? Do you have experience in ACT? What is your approach to working with individuals with chronic pain? Again, back to that advocacy idea that you are a partner in your care, and you deserve every right to question and to ask your provider about their experience, their expertise, and what kind of interventions or treatments they have available for you.
So let's summarize our talk tonight. So there is no question that pain is a complex phenomenon. We talked about definition of pain, about the sources of pain, triggers of pain, different types of pain, but it's not untreatable. We discussed a few approaches, few strategies, how to manage pain, including non-pharmacological, psychological approach, and pharmacological approach. Important for you to always work with your medical team. This is essential to really manage your pain optimally, and also discuss it with your family. They need to be aware when you have pain and what's the intensity of your pain and how it affects your behavior or your relationship. Always open communication is very, very healthy. You are not alone. We have seen, based on our polling question tonight, that 50% of you experience both neuropathic and musculoskeletal pain. So hi, it's half of all of you just attending our lecture today. What's more important is that it will take a few different approaches to really manage your pain. And sometimes, as Abby mentioned, you might have reduced pain, but it's not really gone completely. You have to be patient. You have to work with your team. And very often with my patients with MS, I've seen in the past that it takes few different strategies until we manage the pain that they are able to function and do the things that they would like to do. Organizations like Can Do MS, the National MS Society, MS Foundations, and others have few resources, exercise, stretching exercise, educational program. Attend them and really find some resources that will help you. It's definitely, pain is an individual thing, and we need to be creative and manage the pain to allow you to participate and be part of your care team and your society and your home and family. So thank you again for participating in our program from both Abby and I think we're opening the stage for questions.
We are. Thank you both for some really informative information. So thank you for sharing that with us. We did get a number of questions this evening, and I want to start with Abby. And the first question came in about managing pain with your family members. So one of our participants writes that that she has constant pain, but she doesn't know how to express that pain to her family and how to get them to understand what she's experiencing.
Yeah, that is such a great question, and I hope if your family is not viewing with you tonight that maybe they can view this recorded webinar and some of the other educational materials available through Can Do, specifically geared towards support partners and family members. You're right, when it's an individual experience, when it's an internal experience, it can be really difficult to describe and explain, and sometimes people think that their partners don't believe them or their families don't believe them. I've had partners say, oh, my husband or my spouse thinks I'm lazy and that I don't want to get off the couch. And it can be really demoralizing when it invalidates your experience of pain. And so I work a lot with analogies. So if describing your pain as, on a scale of 1 to 10 is not working for you, you can use some of those descriptor words that we provided earlier in the slides to describe what your sensation of pain is like for you. With the understanding is that they may never experience what you're experiencing, and you're asking them to trust that what you're saying is real and valid, and it's interfering with your functioning. And the best thing they can do to support you is to say, I believe you, I support you, and how can we work through this together? How can we, help maybe refocus your attention when you're particularly having, some rough spasms or some really intense pain intensity? If heat exacerbates your pain, what are some ways to make accommodations in your home for it to be cooler? Especially in the hot summer months. There's a few different ways to go about it, but another way could be, if you ever do meet with a psychologist or a mental health professional, to include your family or a family member in at least one of those sessions. I find that having it come from a provider can be a supplement or complement to your experiencing it as well. That sometimes people hear it differently. It makes sense in a different way. They might get a handout that resonates with them, but it doesn't put all the burden on you for explaining it.
Great. Lisa, a number of our participants noted that their pain is worse at night. Is there a specific reason for that? And do you have any suggestions to how to manage that?
So often when you're at night, when you're not really busy, and I think we have mentioned earlier that sometimes the exercise and the relaxations for different reasons can distract our mind from our pain, so we less concentrate on the pain. And so sometimes at night we have been busy all day long, and at that point all our concentration is really on the pain sensation. It's usually quiet rounds, and the only really things that we concentrate on is the pain sensation. So very often, it's very highly common that our patients will say that at nighttime they feel more the pain because they're not as busy, they're not doing anything, and sometimes it can be related to managing the pain. Perhaps they're taking medication during the day and not at nighttime. So we can probably strategize it, and we can either, whatever modalities to relieve the pain has worked, we can think about timing of different activities in the evening, or if they are on a medication, any pharmacological intervention, we can gear the to the nighttime. So taking perhaps sometimes during the day and either at night. Very often the antidepressant, I tell patients to take it at night, so they have more of ability to a bit relax and have less pain that throughout, so they can really have a good night's sleep. It's so important to do sleep hygiene and sleep well at night. So I always try to navigate and individualize the care if patients really have pain at nighttime. If it's related to spasticity because of immobility or more difficulty moving at night, and sometimes the postures and lying in bed, or either sitting after a whole day, there is an increased spasticity. So I can try, for example, example, there are medications that are muscle relaxants. Tizanidine, for example, works for pain and relaxing the muscle. So we can sometimes really troubleshoot with patients and think, what is the type of pains that they feel? Is it the spasticity? Is it the tone? Is it neuropathic? Is it because it's really quiet and they're tired and the pain was exacerbated from all the activity they've done throughout the day? So I think the most important key message that I can give patient is that we need to always individualize the care and the management, and that's why we always, when they come to a visit, they should bring it up if clinicians do not, as they mentioned earlier, and really discuss the pain and how can we manage it to the best optimally to really allow them to sleep at night, rest, and be energized the next day.
I'll just add a quick add-on to that too, that, and Aliza, you described all the reasons why pain can increase at night. We also have cycles in our body throughout the day that includes cortisol levels, and cortisol is a steroid. So cortisol tends to decrease over the course of the day. So sometimes it is a protective effect against pain during the day, and as it decreases overnight, people notice their pain more, especially as they slow down for the day. Our body temperature also increases over the course of the day. So again, if you tend to be more heat sensitive and you tend to get more hot, you might notice that you feel more pain when your body temperature rises, and around that bedtime period is sometimes when our body is at peak temperature. So there's the combination of environment, internal, physiological, emotional reasons why that pain can be worse at night.
Great, thanks, Abby. Aliza, we had a number of people note that they have foot pain or feet pain. One person noted that it feels like my shoes are too tight when they are not, and I'm walking on rocks. Is there something that you can do to manage specifically foot pain?
So I think the rule of thumb is to check the foot and just make sure that there is no physical and physiological thing, like something unrelated to MS, could be bunion or anything that put pressure. But if they checked everything and everything was ruled out and just a sensory sensation, I sometimes really check the color of the feet. I looked at different ages. Sometimes the feet of patients with MS are discolored, but not related to vascular problem. So you have to make sure you rule out all the medical problems that can lead to that tightness and the feeling, the sensation of the foot. Important sometimes to use other modalities. Sometimes massage can help the sensation, sometimes even loose shoes, although it's not really the shoes, it's just the sensation that's caused by MS, and that's usually defined as neuropathic pain that can be either burning or either pressure-like sensations, or either the shoes, as she described, these patients describe as foot tight, but it's really not. And if it's not swollen and there is no medical issues, you try to sometimes use neuropathic intervention for the sensation, either medical or either non-pharmacological, as I mentioned, massage, or either acupuncture sometimes can help. If that's not helpful and we have tried different non-pharmacological intervention, I usually try the anti-epileptics for this sensation. It's usually very helpful as I titrate up the dose. So sometimes medication can help these neuropathic sensations.
Great. What about, do you have a recommendation in acupuncture in managing neuropathic pain?
I think it's worth trying. We have few good resources in my states that I usually refer the patient to. Acupunctures can be helpful. More so, I've seen it with trigeminal neuralgia, that specific pain that I mentioned earlier. But neuropathic pain can be responsive to acupuncture, and I think it's worth trying and doing it for a period of time to really check its efficacy.
Great. So Abby, I know we talked a lot about resources and suggestions, but can you give one or two of your top resources that help MS patients cope with the severe pain that they experience?
Sure. So I do have to point back to the Can Do library or the Can Do resources as a primary start, because these webinars have been going on for years now, and different pain experts, including psychologists like Don Eady, Kevin Alschuler, others who do this work and do pain research in MS, can really speak to it at an expert level. So I think that's a good start. A second resource would maybe be to look at your local MS center where you go for care and see where psychology fits within that multidisciplinary care, because it is an important component that we know is helpful oftentimes when other strategies are not working, or is a first strategy that may prevent other more drastic measures to be needed.
So one of our participants writes that if they overdo it a little bit, they end up paying for it and need to spend 2 to 3 days in bed afterwards. Is this common in MS patients? And do you have some strategies to avoid that overdoing it? And what would you recommend in that case?
I'm sorry, what was the first part, Laura?
One of our participants writes that they overdo it a bit. And when they overdo it, they end up spending 2 or 3 days in bed afterwards. What kind of recommendation would you give for that kind of situation?
So yeah, I think that's probably related to pain management and fatigue management. So I think it's always important to pace yourself and listen to your body. I always tell patients, if you have pain or that really you feel that you need to do certain numbers of chores that day, you need to divide them and really try not to really overdo it. But it's really up to each individual, I think. But although the effect of really staying in bed is not, it's not a preference really, because then you create and you lead to other complications by staying in bed and not moving around. And if you already have stiffness, it can be worse. So staying in bed is usually not the optimal thing, although sometimes you have to. So I would say pace your activity, make sure that you not overdo it. Always try to listen to your body with the least warning. Pay attention. I sometimes refer patients to occupational therapists to just discuss over time what are the activity, how can you pace activities, how can you manage it step by step, and really not overdo it. Because if the outcome is staying in bed for a few days, then it's not the right probably idea for you. If someone overdo it and it doesn't really affect them and it gives them quality of life, so it's okay and they can really go ahead. But if the outcome is not favorable, it's important to really know what your body is capable of doing and really listen to it before you crash.
I think one of the challenges with this question is that because pain can be so variable, what sidelines you one day could be totally fine the next week. So it can be tricky to say, hey, I just, I mowed the grass last weekend and it didn't, knock me out for 2 days. Why did it do it this week? And it can be really frustrating with that level of unpredictability. And it's hard because in order to pace ourselves or manage pacing, we have to quit while we still feel really good. And that is incredibly difficult to do when you feel good, right? You want to do as much as you can. So I'll often recommend to patients when I'm at least first working with them is to have a pain diary or a log of all the activities that they're doing and try to chart under what circumstances the pain becomes more exacerbated. And then to kind of look to prevent the pain by cutting off activity before that happens. So tracking can be a helpful way to do that, again, with the understanding that what happens this week might not happen next week, so tracking it for a month might be helpful to get a sense of the variability. But it is difficult, and it's that pacing piece is hard, especially in the world we live in. If you have responsibilities, and we all have responsibilities, but if you are overworked right now, taking a break might not feel like an option. So finding ways where you can interject some small breaks throughout your day can also be a helpful way of managing that.
Great, thank you. So I know we touched a little bit on cannabis and CBD. So, and I know that there's not a tremendous amount of research out there, but I do want to, one of our participants asked what the difference between CBD and THC is. Can you give us a little explanation on that, Elisa?
Sure. So the THC really, it's the products that really make you feel a little bit on the high side, really. That euphoria feelings, that good feelings that everyone really, I think, either the effect of this. CBD, it's more the clear carbonidol products that really help the stiffness without the feeling euphoric or feeling high or feeling that pleasurable escape moment, if I can say. And most of the products out there have the combination of both. There is almost no products that only have the CBD that really address your pain sensation or stiffness. Although, again, the studies are limited, or there's not a lot of information about this. And then that's the difficulty, that we don't really know how it affects your cognitive function. There are studies that it's not really helpful in neuropathic pain. So the two products really have a difference in effect. For example, the one product that is going to the FDA by the end of this year or next year has a combination of both as well. And it seems that the combinations actually really treat better the pain, is more effective. And that's the reason that most companies have the combination of both CBD and THC. It just has been more effective in minimizing pain and stiffness, even in the limited research studies that we have.
Great. One of our participants wrote about pain tolerance. So she writes, when you live with pain, you often get used to it, so that your pain tolerance increases. Is this normal, or can this cause additional damage that is not being addressed? So
it's more related to taking medication. So we define tolerance differently than really addictions, and then really tolerance as described by this patients really over time. But the issue is that most patients really develop tolerance to medication, and especially to narcotics, because over time, once we build tolerance, it becomes really a bit less effective. And that's the reason you need higher dose and higher dose. It happens, for example, with Percocet, with oxycodone, with the family of narcotics. So once we build tolerance, we need more and more medication, and then we can experience more side effects. And it's different than addiction, when you actually really need the medication, and without it you cannot really function. So the only issue behind building tolerance, and it's more for medication rather than pain, I wish patients will develop some tolerance and it won't feel the pains. But to medication, the only problem is that people require more and more medications to manage their pains once they start being on narcotics. And I think that's really the issues. And then they've developed the constipations, sometimes depression of the central nervous systems because of too much of narcotics, and many other complication effects on the cognition and alertness. So it's important to really, if you have to take narcotics, it should be for a shorter period of time, because before you build up tolerance and increase the dosage.
I'll also speak to the pain tolerance piece. So there may be some numbness that people experience that it reduces the experience of pain or the sensation of pain. And if that's the case, then your risk of injury is probably greater, because you wouldn't know if you have numbness, then you wouldn't know if you were actually really injured. Pain tolerance is more the idea that the pain is there, it's just that you can tolerate it more effectively. So the degree to which, how harmful it would be, it's kind of going to depend on what activities you're engaged in and what is the potential for injury. If there's not a high risk of injury, then maybe the pain tolerance is actually adaptive for you, and something to, I wouldn't say be celebrated, but something that's working in your favor right now. It could also be that the difference between chronic pain versus acute pain, and there are many differences, but one of the differences is that chronic pain is sort of a signal that something is wrong and that your body's being damaged, when there's actually no tissue damage happening. And so if you're able to tolerate that chronic pain in the absence of real tissue damage happening, then again, that may be more adaptive. So it's kind of figuring out what is the risk of, are you getting injured? And if so, then even if you have a high pain tolerance, maybe that for you means that you need to start paying more attention around a 4 out of 10, because by the time you get to a 6 out of 10, then you're at more risk for injury.
I think though also the point is that if patients are treated, then they're okay. So that means we see some optimal, hopefully, response to our pain interventions. I would hope so. So perhaps that's also what happens. So anyhow, I think it's often a good optimal outcomes, and if patients really have reduction of their pains.
Great, thanks. It looks like we have time for one more quick question. Abby, how do you get yourself motivated on the hard days? How do you deal with feeling like you're not letting your MS control your daily life?
How much time do I have? No, it's a great question, and actually, I was just talking about this in a different group this evening, of that motivation oftentimes does not come internally. It doesn't have to come internally. We are motivated by external factors all the time. So if you're feeling unmotivated about something, but it's a goal that's really important to you, that's where you can use your support network or find other external things that motivate you to kind of get you started. Sometimes barriers to motivation include things like setting goals too high. So if, let's say you have a pie in the sky, or really long-term goal that you really want to accomplish, but it's going to take a lot of steps. It's easy to get overwhelmed, and then it's hard to feel motivated when you feel like you can't see immediate benefits. We have whole other talks about goal setting and self-management, but that's really a place to start. Is if you're not feeling motivated, maybe the size of the goal is too big right now, and identifying something that you feel like you can do more effectively in the time that you have to do it, with the energy you have to do it, might get you more excited about it.
Fantastic. Do you want to add anything, Lisa, before we conclude tonight?
I think that, as we discussed, I think it's really important to really think about how you can manage your pain and really identify it. And I think the most important thing for me as a clinician and a provider is that you discuss it openly with me, and that we can manage it together as partners. And I think that's the most important things in future management or better management of pain.
Those are two great notes to leave on. So thank you both for some great information and some things to think about as we move forward with this difficult thing to manage. So with that, I'm going to say thank you to everyone out there for joining us this evening. I would like to remind you of some resources that are available. Abby mentioned quite a few times that the Can Do MS has a number of resources. In addition to that, you can also connect with us socially via Twitter, via Facebook, via Instagram. We have some great resources that we put out there on a regular basis. So don't hesitate to look at our social media. And also, I would encourage you to look at some of the resources that are available from the National MS Society. They have a variety of brochures and video segments that can be accessed on their website. And most importantly, you can contact an MS Navigator. That is a great service to utilize. The number for the MS Navigators is 1-800-344-4867. If you have a question or looking for some local resources, don't hesitate to give them a call. Now, I would like to tell you something special about September, because September is Can Do Month. The founder of our organization, Jimmy Yuga, it's his birthday month, so we celebrate Can Do Month every September, and we want you to share how you thrive with MS. So you can do that by submitting images or videos showing how you live passionately by running, painting, camping, traveling, cooking, singing, loving. Any way you empower your community and thrive with MS. So take a look at our website and let us know how you are out there thriving with MS. We want to share it with the rest of the world. Finally, we have Jumpstart programs that we're offering. We still have about 5 or 6 left throughout the end of the year, and we're doing those virtually. They previously were an in-person program, but now due to the current situation, we're offering these virtually. So I would encourage you to take a look at our website and sign up for the next Jumpstart, which is September 15th. And it is an interactive discussion that you can share with other people with MS and get some resources from them, from some healthcare providers. So I'd encourage you to join our upcoming Jumpstart programs. In addition, we have something called Can Do On Demand, which is a great resource that you can do on your time. So take a look at Can Do On Demand. And finally, the next webinar in our series is going to be on bladder and bowel symptoms. So a very important topic that we would like to share with you. And that webinar is going to be on Tuesday, October 13th. So I'd encourage you to join us then. And finally, I really want to thank you for participating with us tonight. And I would ask you to complete the survey that's going to pop up on your screen as soon as the webinar concludes. And it just gives us helpful feedback to make these programs better for you. So again, Eliza, Abby, thank you so much for participating tonight. It was great having you. But with every one of these webinars, I'd like to thank you out there for joining us and giving us your time and taking this time for yourself. We very much appreciate you coming and using Can Do MS as a valuable resource. So thank you and have a wonderful evening.
Good night. Good night,
Bye.
everyone. Bye.